We're right on time. Good evening, everyone, and thank you so much for joining us tonight for tonight's Waxing Clinical session. Today, we'll be unpacking the impact of information sharing on the continuity of care, as well as talking a little bit about the value of discharge communication in improving the patient journey. I'm Dr. Pitsy Kiwana, and I'm joined by Dr. Untitled Chapter, our Group Medical Director, and we're going to be taking you through this information through a presentation that's been structured to bring in both the patient perspective as well as the clinician perspective on this important subject. Second, sorry, just having a pointer issue. Give me 1 second. Okay. Right. Okay, I think that should be resolved. Let's see if that's working now. Now let's see. I'm sorry, everyone. Technology sometimes is not on our side, and today is one of those days. So give me 1 second. I'm just going to switch to another pointer. Yeah, we might have to do it that way. I'm sorry, everyone. Okay, there we go. All right. And so I'm going to hand over to you to start us off, and then I'll come back into the screen to take over.
Thank you, everyone. Good evening and welcome to our next Waxing Clinical webinar. Thank you for giving us some of your valuable time this evening to cover this important topic. So the information that we're going to convey will be structured as follows during the presentation. And we are going to share some videos to give feedback on interviews we've had with patients and clinicians, specifically on the topic of the importance of patient information conveyed post-acute care or other care events, and the benefit that has, or the application that has to their specific practices. I'm going to speak specifically around the value of information sharing, touching on who are the different stakeholders that we believe could benefit from that, and also what is the important constructs of clinician engagement, because it's really critically important that we make this information fit for purpose for our clinicians, easy for them to participate in, and really of value to everyone who we've identified as stakeholders. Dr. Pitsy Kiwana, our Clinician Engagement and Patient Experience Manager, is going to take us through what is Netcare doing to support the continuity of care. And there we are going to focus on these interviews, and also going to unpack some more information that we have harnessed from interviews with our clinicians. And then the interviewees that we have invited to participate is Dr. Martin Kramer. He is a general practitioner in Maritzburg, working in one of our Medicross facilities, giving a general practitioner perspective. Dr. Peter, who is a specialist nephrologist at our Milkwall Hospital in Johannesburg. That's very specifically a specialist. Charlene Murray, who is both a patient as well as a nursing staff member, is going to give us her view from a patient angle, but you will hear as she speaks, she also gives a bit of a nursing perspective on the importance of information sharing, and specifically discharge information. So thank you very much, and we're going to go through to the first interview.
Thank you so much, Anshin. So I'm hoping that our pointer is going to be working now. There we go. Okay, I saw a laser light up. The pointer's not doing what it needed to do. I'm really sorry about that. Thanks, Anshin. All right. We had tested this, but technology is technology, and sometimes it's not on our side. So as Anshin said, we've got a couple of perspectives that we're going to be sharing today. The first perspective that we wanted to open up with is a perspective from Charlene Muravan, who is one of our nursing staff members who was recently involved in a health admission at one of our sites. And she's going to speak a little bit to her experience in terms of what it was like to go through that experience, especially as a patient, and sort of not having access to the information that she needed to really kind of actively participate in that care experience with her healthcare. If you'll just give us 1 second, so we can just make sure that the slide will turn.
Yeah. Okay.
Very important point, Pitsy, because when I was admitted, I found in all of the strength that I needed. I still had to explain myself from the previous year. I know I'm gray, but I actually thought to myself, like, it just happened last year and I can't put the pieces together. I have no idea whether I went for a left side oophorectomy or a right side oophorectomy. I could not remember for the life of me. I could not. And I was in so much of I was in so much of pain. And I was just telling this the gynae who I've never met before, but he's the person that can help me right now because I cannot drive to Rosebank. I can't move anywhere. And I am just telling him any information, you know. Because in my mind, I'm thinking he's gonna see it when we get to theater anyway, you know. And then I'm thinking, okay, but what if he cuts on the wrong side or what, you know? But then there was an ultrasound to see, but I could not for the life of me. You bring up such an important point. I couldn't remember properly I couldn't put the dates. Whatever I was explaining, you could see he was just taking that information because he can't get anything else anyway. But I had said, who's my previous gynae? Throughout my stay there, I don't think there was any contact, if you ask me. I don't think there was a contact made to the previous gynae. Up until now, she doesn't know that I went to take out the other side, so she doesn't know anything. But I wish there would be something like that, that when you go on, just like right at the beginning in nursing, when we were trying to use the journey of the patient file, where you use one file and you carry it throughout the patient's stay, whether they go to ICU, come back from ICU, back into the ward, because there were just too much of opening and closing files and losing information of the patient, you know, and everything is just kept in different places, and you're calling back for information when records are closed, and it was just too overwhelming to be looking everywhere. So if we can have something like that, where if I go to like I went to Rosebank as the patient, and then when I go to Mulbarton and my name is seen there, you know, all the information that comes up to the doctor, I think it would save time also for the patient explaining. Trying to remember in that excruciating pain was terrible, but it's not any fault of his. He's trying to help me. But I think that it would have really helped in that situation. And I think for other patients out there, for other nursing staff out there, and even for doctors out there, it will really help, because not everybody can remember what they've been admitted or what was done in their last admission. I mean, look at me, I couldn't remember anything. I just could not remember it. I felt like I had lost a side of my brain or something. But imagine the elderly person. Imagine a child whose parent is not there, and a granny is taking care of them, or even a cousin or an aunt or an uncle, you know. Or imagine me, where it's one of my kids. My husband, he doesn't know much. It's always me that's going there. So if he's there, he's not gonna know, because I'm the one that had taken them, you see. So I think it would really help to have that journey up already, so that they can see. Very important point, Pitsy, because when I was at
Thank you, Betsy, and apologies again for the IT glitches. We tested this before, and for some reason our slides don't want to move. So I'll be sitting here and Betsy will be moving the slides, but I hope it doesn't detract from the value of the information that we want to share with you this evening. So we almost always share this value slide where we depict value of care as a mathematical equation, but also refer to the quintuple aim as a very well established and widely published and used model on the right side of the slide. So when we talk about, you know, a clinical event, whether that was an admission to an acute hospital or the consuming of care in any one of our other types of facilities or service platforms, we talk a lot about the best outcomes, and we publish and monitor quality of care outcomes across our different operating domains. And as clinicians, we are very much focused about providing the best and the safest care to our patients and knowing what our clinical outcomes are. We harness experience when it comes to the more subjective elements of care and to understand how we could make a care event for a patient, which was already a stressful event in and of itself, a more pleasant experience. And when it comes to the cost related to care, I think patients will be very open to say that there's very detailed account statements provided to them from all the practitioners and the institutions involved in their care, given a care event. But who puts all of this information together for the patient, specifically around what was the provisional diagnosis, the final diagnosis, what treatment modalities were instituted, what was the chronic medication, what was the discharge medication, and all other relevant information that to Charlene's point, first of all, she was unable to convey to the healthcare practitioner who picked up her acute care event post previous gynecological surgery. And then afterwards, after this care event, if she has to go back to the referring gynecologist, would she be able to replicate that information? And thereby, even if we do believe and we do try our utmost to provide value of care to a patient, we lose some of that value if the information that pertains to that event is not replicated and going further than that actual acute event. So that is why we wanted to just pause on this model. Constructs guiding continuity of care, I just want to talk about these 4 elements, and I'm going to leave legislation first and actually just start with clinician engagement, because that is why this webinar was very important for us to kick off on this topic. Some of you may recall that during the course of the year, earlier on in the year, we polled our clinicians to ask whether they thought that discharge information was valuable in the continuity of care, whether they would be willing to participate in providing discharge information, and also whether they would like to call a discharge information something alternative. We settled on the term summary of care, which was widely recommended and accepted by the clinicians who participated in the survey. And we embarked on a process of designing these summaries of care across our different operating platforms and divisions in the Netcare ecosystem, and specifically empowered by the electronic health records that we are currently rolling out across our different divisions, which allows for the population of a fairly consistent looking summary of care document at the end of a care event, whether that is in the dialysis unit, the cancer care unit, an acute hospital, a psychiatric institution, the emergency department, a 911 ambulance, or a Medicross GP or dental facility. So just pausing a little bit on clinician engagement, what we are going to do going forward following this webinar is we are going to engage clinicians in our different divisions. We are going to do so on a societal level where these are available to us, as well as with key opinion leaders as influential individuals to harness their feedback on our process, on the proposed summary of care, and also as we move forward and develop it further. In engagement, it's important to convey the rationale. So the summary of care, first and foremost, is aimed at a group of stakeholders, the patient as the main group of stakeholders. So back to what Charlene had said in an interview, it's about empowering them with the information that they don't necessarily understand or are able to replicate, because they may or may not have a clinical acumen, but also they are confronted with so much information and so much uncertainty during the care event that they can't necessarily contain and replicate this information either to their referring clinician or to a clinician they encounter in a later care event. So the stakeholders are very important. First and foremost, the patient. Second set of stakeholders are the clinicians. Clinicians are important both from a referral perspective, and later on in the set of slides we're speaking specifically to the general practitioner, who speaks very much from the angle of referring patients into acute facilities and what would be the benefit of receiving feedback on his patients' care events. And then also clinicians encountering patients further on in their lives. So the example of Charlene presenting to an emergency department in an unplanned context, and being able to call up the information that is important for the clinician and taking care of her. So it's not only the network of specialists or GPs that you go to on a chronic basis, but it's also the unplanned events where you may be unconscious or uninformed or just unable to convey this information. And in the third set of stakeholders that's important is the funder. So our discharge records, specifically from the acute context, go to the medical aids that fund the specific care event for the patient, and it allows them to harness certain clinical and coding information that in turn is really important to do accurate billing, but also to put together an accurate clinical picture of the risk and of the benefit provided to their patient. So those really are the three sets of stakeholders, and our focus this evening is really on harnessing the clinician input in this process. I'm going to jump back to the legislative requirements because from a clinician engagement perspective, it is important that we understand the onus on us as clinicians to provide a detailed discharge information. And there's really three pieces of legislation that talk to this. Firstly, there's the National Health Act, 61 of 2003, in section 10, where it speaks about what is a health record and what is the responsibility of both the institution as well as the participating clinicians on providing a health record. That links to the HPCSA ethical booklets, where they unpack in a little bit more detail what constitutes a health record. And in that, they specifically refer to comprehensive information pertaining to the discharge of the patient. The most detailed of the legislative frameworks is in the Office of Health Standards Compliance, in the norms and standards regulations, which are effected through private sector auditing tools, where they have very specific pieces of information that should be contained in a discharge summary. And that includes demographic information about the patient and the institution. It includes information about the main treating practitioner as well as consultant clinicians, provisional diagnoses, final diagnosis, treatment provided, surgical procedures carried out, and also aspects around TTOs and follow-up responsibility of the patient, as well as, very importantly, health information. So information pertaining to the clinical diagnosis of the patient and the procedure carried out, which in turn has a big benefit to the patient post-discharge to avoid readmissions or recurrence of the incidents. So that's really just covering the legislative framework. Carrying on with clinician engagement, is really important for us to harness from the clinicians whether this summary of care as we've designed it would be useful to them. Should they be either the referring or the receiving clinician? Is it easy for you to participate in completing the information required in the summary of care? So as far as possible, through our electronic health record platforms, we will auto-populate most of the information as they exist in the record of the patient, and it will only be required from the clinicians to affirm the correctness of the information or correct it if required. And then it really is very important that the clinician signs off the discharge summary. Without the signing of the discharge summary, we can't provide that information to the patient. And the second last aspect is just around the comfort around adherence to in protection of information and confidentiality requirements, and that is taken care of in consent agreements when the patient gets admitted, but also in adhering to all of the protection of personal information legislation in the POPI Act as well as the National Health. And then the last thing around the clinician engagement that it's important is, as we set out on this journey around the summary of care, we have prototyped initial design that we are going to populate and engage on. And there will be an opportunity to improve on this and to provide richer information as our electronic health records mature and as clinicians participate. I've spoken about the funding requirements. I don't really want to dwell on that this evening. I do think as clinicians, you deal with funders on a daily basis, and it's important for them also, much as it is a requirement from them to be provided with this information. And in the patient angle is really where this all started off, empowering the patients with this information and thereby contributing to a better continuity of care in terms of information flow. So thank you, Betsy. That was me on the constructs.
Thanks, Anshin. So we're going to give this a try again and see if it works now. Okay, looks like the arrows are working, so that is an improvement. Okay, cool. Right.
Our next clinician is the Dr. Peter Sue. As I've mentioned previously, he is a specialist nephrologist practicing at our Netcare Park Hospital, which is a big referral center in terms of acute admissions, referrals, into hospital transfers, locally throughout the country as well as across the continent. And he gives a very specific perspective in his unique practice and in the setup where he works in a quaternary type referral center of the value of continuation of information and the impact of providing this information to better enable coordination of care, a team approach, a multidisciplinary angle to the complex patients that he sees on a daily basis. So let's hear what Dr. says.
Question. So, you know, in these sort of communications with sort of this kind, clinicians or sites that are a little bit outside of maintaining patient continuity of care. So I think maybe a great place to start would just be to tell us your practice, what you do, and sort of the kind of patient profile that you see.
Sure. I'm a nephrologist at Mopark. We look after pre-dialysis patients, also patient on dialysis, ICU acute dialysis. We have a full transplant program here, and we also run a peritoneal dialysis program. We're quite busy. We do see all ethnic groups, religious groups, and different socio-economic class of patients. We're lucky in the sense that we're in a bigger center. So how we approach renal dysfunction is that we're lucky, is that usually our patients bond with us. They're more chronic patients. And we have them for quite a few years. It's unlike the surgical discipline where you do the surgery and they maybe 1 or 2 follow-ups and they don't come back. Whereas we have a long relationship. So ideally, how we work is that if we do see a patient pre-dialysis, we then have a dedicated nurse that is trained to start something called the Healthy Style Program or Our Journey, where the patient is educated as to what to expect in the future, as to what type of dialysis is available, that there is hemodialysis, peritoneal dialysis, or home dialysis. They also get counseled on diet, which will involve a team of dietitians here who we try something different, is more a plant-based or plant-dominant diet for the renal patients. For those who are transplantable, we let them see the transplant team earlier, so there is hope that they won't be stuck on dialysis lifelong. Unfortunately, 30% of the patient who eventually require dialysis becomes depressed. We do have a psychologist here who communicates with them, and also we try to get other patients on dialysis, probably of the same ethnic group or religious group, to talk to the patients. So there's a certain form of support and bonding. So I'm lucky because to do that for the doctor is not easy. And our biggest problem with doctor, we all know we need to communicate more, but the biggest constraint is time factor.
The Mopark area, or even perhaps maybe inside. You know, what I'm hearing from you is that a lot of that communication comes directly from your office into these individuals. So you communicate quite directly, but at the same time, you empower your patients still to understand what's happening in those communications, so that even though you've spoken to the charge sister at this remote site, they also know as the patient, this is what's happening.
So I'm lucky, I have 2 PAs here, and they've been with me for like more than 20 years. So with time, the patient gets to know them. So they know that if they tell them something and they pass on a message and I relay the message back or via email, they know it's coming from us. Not always possible to phone them because our days are very long, but they do understand that. And sometimes they tell us they need to talk to us and we make that time. But most of the times are very routine, like you know, their hemoglobin, whatever, is a bit low, then we adjust the dose, and my PAs phone them and say, look, these are what is decided, or they email them in point form. So we try and keep communications open, but succinct and to the point. For those who had transplant, then it becomes more difficult because of immunosuppression. What we do is, once a transplant is successful, the transplant team will have 2 coordinators who sit with the patient with a picture of the medication and educate him for about almost a week, so that the patient knows exactly the dose and each drug and what is used for. Because many times we dose them over the phone. When I phone them, they know how to follow the dose on the instruction on telephonically. So that education is very important. Post-transplant, that type of communication is vital. So in a way, I'm very lucky that we have many allied health who are very experienced, who could take a lot of burden off the communication and save us time. So that I'm very grateful for.
Thank you. We've also honoured some further feedback from a variety of clinicians that Pitsy is going to speak to in detail. But I think what is important to what Dr. Sue had conveyed is that time is really very scarce in the day of any clinician. And it would be helpful if information can be succinctly provided to yourself when you see a new patient, give you full context about the patient. But in the same breath, when you have to populate this information, you don't have a lot of time, and it needs to be as user-friendly for you, and thereby it will be really important for us to harness your views on what we provide from a digital perspective to you, to populate this information, to do it as efficiently in the limited time that you have. So over to Pitsy for the balance of the clinician perspective.
Thanks so much, Anshin. And I think, thanks to Dr. Soon, also just Anshin, for highlighting some of these points. When we're talking about continuity of care, one of the things that we realize is that every single healthcare worker in the patient's journey can benefit from further or better communication between the different individuals. So when we look specifically in the hospital setting, in our engagements with some of our clinicians in hospital, one of the things that we realize is that sometimes there's a lack of communication between hospital physicians. So even from a specialist to a specialist, we find that sometimes that communication is lacking, it's incomplete, and that can obviously then impact the care of the patient. So really, where we see this kind of communication also fitting in is between clinicians, even in a hospital setting, where there is some kind of documentation, there's summary of care that the patient can then take from one clinician to another, that would have all the information in terms of the care that they received, the medication that they're on, and any other sort of treatments that were carried out for them in the hospital setting. The next video we're going to look at is going to focus a little bit more on the from hospital to home, which I think is a traditional sort of method or place where we see this kind of communication. And it does not lose any importance, because it's still important for the clinician who's caring for the patient at home to understand what happened in hospital. Oftentimes, GPs have no context to the hospital stay, they have no context to what procedures were carried out, and patients themselves, even when they're healthcare workers, as we saw with Charlene, can sometimes forget the details. So really, the big benefit of this from that stakeholder group is having that communication between our in-hospital clinicians and our clinicians in the hospital setting to then optimally continue the patient's care and ensure that the patient continues to optimally recover in the post-discharge or the out-of-hospital setting. Another important stakeholder group, which Charlene had mentioned in the initial video, is around the clinicians that patients will see in an ED environment. Patients can arrive to ED unconscious, unable to communicate, in pain. They might be elderly, they might be young, and even for patients with a healthcare background, it can be difficult in that moment to recall the details and the specifics of their care if they were previously admitted. And so really the other benefit here is around being able to actually empower the patient to enter into that ED discussion or that ED sort of moment and know that the clinician is going to see them, is going to have an up-to-date record of any previous sort of hospital admissions, any current medication that might be taking, and then any sort of significant events that might have occurred in their previous hospital stay. And then lastly, and definitely not least, another group of healthcare workers that we often don't communicate well with are our allied healthcare workers. Allied healthcare workers often rely on patients themselves to understand exactly what's happened to them. They don't always have the full context. So being able to provide our allied healthcare workers with a much more comprehensive history of what the patient's stay included, and especially what kind of medication the patient is on, is also beneficial for this stakeholder group, who are very important in actually ensuring that patients recover well post any hospital stay. So I'm going to quickly go over back to my laptop just to go on to the next video, but just to introduce it, the last video that we're going to be looking at is from Dr. Kramer, who is a general practitioner, and he speaks from the perspective of a patient or a practitioner who receives patients from hospital, and really the impact of having that communication, that transfer of information from the in-hospital to the out-of-hospital setting.
When a patient gets discharged from hospital, the benefits of receiving a referral letter back obviously is because I know what happened to the patient. I know why medication was changed, if it was changed, and I know when the specialist writes back and says, listen, I want to see the patient in a week again, or a month, or whenever. All right, so the care of the patient is better. That's a positive of getting a letter back. Sad part, especially in Pietermaritzburg, it doesn't happen. Very often we don't get letters back. I think one of the reasons is because the patient arrives in the hospital in the middle of the night, or because of the patient probably sees one more or even 3 GPs. So the specialist doesn't know who's referred the patient. I think another negative aspect then is also I tend to refer to specialists to actually write a letter back. For the simple reason, there's a communication back, I know what's happening with my patient. And the other positive aspect again is I get educated. So I know, oh, all right, next time I'd rather do this or don't do that. So it's in a bit of continual medical education. So we always actually enjoy getting referral letters back. And as said, over the last 32 years, if I get a decent letter back from a specialist, that's usually who I refer to. And I think a form can be done very easily, very simply, just stating, this was the diagnosis of the patient. That's the reason why the medication was given. This is the reason why certain medications were stopped. And that's about it. It doesn't have to be a 3-page essay. Just very simply, this is the reason why this patient was seen and what actually happened in the hospital. Yeah. When a patient gets discharged from
So thank you, Dr. Kramer, for sharing that. And I think as we go into the last section of this, we just want to quickly touch back again on our value of communication, because I think it ties very closely to what we've been discussing. We understand that from our clinician perspective that there's a key part that our clinicians play in every part of the value of care equation, whether it comes to the cost of care, the patient experience, or even the clinical outcomes that our patients experience when they are in hospital. And so for us to truly benefit our patients and to truly have that relationship with our patients that allows them to get the best value from our care, it is important that we engage well with our clinicians, who are key stakeholders in the delivery of care to our patients. So we're going to talk a little bit about what we're going to be doing from an engagement perspective to ensure that as we're engaging on the summary of care project, we're able to get valuable information from our clinicians, but most importantly, we're able to co-create a solution that is going to be both beneficial for our patients in terms of continuity of care, but also valuable and beneficial for our clinicians in terms of making sure that that communication continues and that patient care is optimized inside and outside of the hospital setting. So, in terms of our guiding principles, the things that we've been looking at this year, so some of you will have received the clinician engagement survey that we did at the end of July this year. And one of the key reasons why we embarked on that process is because it was very important for us to understand our relationship with clinicians, because we see our clinicians and partners. We understand that everything that we do and everything that we are providing patients requires clinicians to partner with us in providing valuable care. So when we're looking at the summary of care process, it's important that we emphasize that this process is not something that we're doing independently. It is something that we are engaging with clinicians on to make sure that the end result and the end product is something that is of value both to our patients, but also to the clinicians who will be using it, not just as the clinicians who are going to populate the document, but as the clinicians who are going to receive the document and potentially send the patient on with this document to the next carer. I think the next point that we want to also emphasize is that one of the things that we've picked up in our journey in terms of clinician engagement and the work that we've done is that as we engage with you, one of the things that even Dr. Sue mentioned is that time is a critical factor. Many clinicians do not have time to spend lots and lots of time sort of looking at one document. And so we are going to endeavor from our side to ensure that when we do these engagements, we keep it simple, we keep it very short, and we keep it to the key points that are relevant to the discussion. And we hope that as we're doing that and as we're keeping things very sort of clean and sort of intentional, we'll be able to really elicit the benefit from clinicians, which is one of the reasons we wanted to have this session today, because we felt it important to first position the thinking around this document, the summary of care document, to position the different stakeholders and the benefit that they would gain from that, and then to allow clinicians some time to really sort of think around, what they would like to bring to the table when it comes to this discussion, so that when we have these discussions, we're able to fully elicit the benefit of this summary of care document from our clinician stakeholders, so that we can develop something that will be of benefit to our patients and our clinicians. And then lastly, I think the main thing that we wanted to really also position is the fact that we want this to be a collaborative process. We've invited clinicians to the session because we want to share what we're looking at doing, and we want to share the reasons why we're looking at doing this, but also to show that we really want to encourage this relationship where we're able to co-create solutions that are of benefit to our patients and to the clinicians who work within our institutions.
Thank you, Betsy. I think before we allow for some comments and questions from our clinicians, in our previous webinars, we found that our content filled almost a whole hour. So we intentionally made our slides and the feedback and the information from our side a little bit shorter to allow for clinicians who want to comment and want to ask questions to please participate. So we invite you to please post your comments and questions on the chat box. If you're not wanting to do them this evening, you're also welcome to reach out to us on the contact details provided on the invitation, should you want to further engage on this topic. I think the second important thing is that we do often reach out to our clinicians on various platforms, and we really do so because we want to harness your input. So we would like to invite you again to please participate in these webinars, participate in our surveys, be in touch with us so that we can get your feedback and that we can ensure that this important piece of clinical information is designed that it would be beneficial to you and your patients and easy for you to participate. Just in terms of the way forward and on these webinars, and I'll reiterate that at the closing of this evening, we've got 2 webinars left for the remainder of the year. We are not going to, in the immediate 2 webinars, pick up on the summary of care topic again. We are allowing for the processes around the speccing of these documents for the respective divisions. And just to reiterate, that goes across the whole Netcare ecosystem. So in the acute hospitals, it will be based on the Careon electronic health record platform. For those of you who work in hospitals where this has already been implemented, we are forging ahead ambitiously with the rollout of the digital platform. Been very successful to date, and we aim to have all of our hospitals fully digitized by April 2024. In the Medicross environment, the platform is called Heal, and you would have seen in the video with Dr. Kramer, we were joined by Dr. Katalain Zeilenmaker, the medical director of the Medicross division, who is spearheading the clinician engagement on that platform, and the discharge summary that is uniquely adapted to the Medicross, the GP context, is led by her and empowered by that medical record. In the nephrology space and our dialysis units, our electronic health record is called Nephron, and that has the participation of the clinical technologists and the nephrologists in the dialysis space, and the summary of care is then also uniquely tailored to that environment. Same in our cancer care space, where initially our summary of care will focus on the radiation environment, and then in due course will also go to the medical oncology or the chemotherapy environment. Netcare 911 has been fully digitized for some years, and the electronic patient report form will also now continue into a discharge summary, either from the scene where the care was provided or upon dropping the patient off at a facility. And then lastly, our mental health clinics at CASO also has a version of care on uniquely adapted to the psychiatric context, where in the doctor module, the summary of care will also be populated uniquely applicable to the psychiatric environment. And so we look forward to seeing you in our next webinars, and we hope to pick up on the summary of care topic in our first webinar of 2020. So over now to questions and comments.
So one of the questions that we received is around confidentiality. So I don't know, Anton, if we can elaborate in terms of the confidentiality of this document. Do we have any thoughts in terms of how that will be managed?
So I know that there's a very important gatekeeper for clinicians to participate in the population of a summary of care. So firstly, the health record of a patient belongs to the patient and needs to be accessible to all clinicians who has clinical context to the patient, and then also in turn certain administrative functions such as case management and the funders. So when a patient admits him or herself to a certain level of care, a certain facility, they do sign consent, and in those consent documents we've taken care to allow the patient to understand that this discharge summary will be issued post-discharge. The patient also will have the option to deselect the issue of the summary of care, so that if patients opt out of this, this information wouldn't then be distributed. The information will go directly to the patient who is the patient being taken care of, or in the case of a minor, the person who acts as the party who gives consent to the medical treatment of the patient. So that will be very streamlined and not widely communicated, but only simply to one person. And it will be up to that person then to share that information with whoever that person wants to share it. So also on the consent part, if you don't select that your discharge summary needs to be provided to your referring practitioner, it's entirely within your choice as a patient. And over and above all of this, all healthcare information on our electronic health platforms and our data systems are governed and protected by all the necessary legal and cybersecurity requirements, as is the gold standard.
Okay. Thanks for that, Anton. And then one of the other questions that we have is around participation. Is there a view that this is something that clinicians will need to participate in?
So I think what we try to convey this evening is really how that would be of value. I think it will depend on whether the clinicians find it simple to participate with and whether they see the value in that. So therefore, I think it is important for you to, when that document is shared with you, to look at it from that angle and say, is there something that I want to spend my time on populating? Is there something that will help me when I see a patient with such a document? And I think those are very important aspects. We are going to measure as one of the key performance indicators of the success of this project, how many discharges are actually effected and for how many of those are summaries of care populated. And we're also going to look at the quality of the information, because I think we all agree that we wouldn't want to issue a document with poor quality, maybe because wrong information was pulled through or it wasn't reviewed and signed off by the clinician. And as I said, participation of the discharging clinician is essential in releasing the summary of care. So without the discharge being effected by the clinician who discharges the patient and the permission given for this to be given to the patient, that also can't go ahead. So participation is actually the key ingredient that will ensure the success of this project.
That's very, very true. Thanks, Alancha. I think the last question that we'll take is around the time aspect. So concern here raised around, the time to actually populate the items on a digital platform. What are we sort of thinking around just combating that time aspect and not perhaps creating something that might add more time to the clinician's process?
So I think it's a very important question, and maybe to answer a little bit broader, our care on team, specifically in the acute hospital context, but also in all of our other divisions, understand the importance of clinician engagement and the critical dependence on clinician adoption and the use of electronic health records. We understand that initially, as one has to get used to the record, you have to train, these administrative tasks pertaining to record keeping will take longer. But we also see that as clinicians become more used to the record and more used to digital record keeping at the bedside, and that includes our nursing staff and our pharmacy staff, that time reduces and that it becomes more efficient in terms of the administrative aspects. And I think the same goes for summary of care. So we've engineered it slightly differently. We mapped out what we call a minimum viable product, which is a comprehensive discharge summary, meeting all of the regulatory and legislative requirements, but still something that is as far as possible, automatically populated out of the electronic health record, and also easy to perfect. It's difficult to not say it that way, so that there is not a lot of margin for spelling error or language error because one is in haste, that there aren't big areas of information that has to be populated that will be left blank if a clinician, for example, doesn't have the time to complete that piece of the discharge information. So it is a set of information that will be predominantly auto-populated, will require for the clinician to review, correct if necessary, and sign off. So we have designed it in such a way that it is not going to add an enormous amount of administrative time and effort. But if a clinician didn't previously complete the discharge summary, which we know is oftentimes the case, then that will, by virtue of being present in the care episode of the patient, add some administrative time to the clinician's workflow.
All right, no, thank you, Angela. I think that brings us to the close of our questions. So we just want to thank you so much for the time that you guys have taken to join us today. As you've noted, we've adjusted our sessions so we can actually give CPD points for these sessions. So all the people who've attended and who did register will receive CPD points. And then, as Angela's mentioned, we have 2 more waxing clinical sessions scheduled for the year. Our next session is going to be focusing on a very topical topic around nursing. So we encourage you to join in and to invite your colleagues to also join in, as I think there are a lot of very pressing issues around nursing that need to be addressed, and we're going to be taking that time to address that during that session. So thank you for your time, and thank you, Anton, for leading the session, and thank you for being with us with our IT issues, and we hope you enjoy the rest of the evening.
Thank you very much, and good evening all.